In this video, we're going to start out by talking about normal bowel gas patterns. So the bowel is normally going to be distended due to the presence of gas, fluids, stool, etc. But dilation of the bowel is abnormal. And the stomach is also almost always going to contain air, as we've talked about previously. The normal bowel, or diameter of the small bowel, you'll want to note, is typically less than 2.5 centimeters. So if it appears larger than about 2.5 centimeters, you should be thinking that it might be a dilated bowel, small bowel. Usually we can see 2 or 3 loops of non-dilated small bowel on a typical abdominal plain film. And so I wanted to go back to an image that you saw previously where this white arrow here is clearly pointing out a loop of small bowel right here. I think when I talked about it before, I was saying that you could see the ascending colon. I was admittedly just reading off the list, but here you can see where this is a loop of small bowel and not the ascending colon. So again, you can see the plica or plicae circularis right through here. And so that tells you that is definitely a small bowel that you're looking at and not large bowel. I also mentioned before the air fluid levels. I wanted to come back to that while we're talking about gas. So sometimes where there's gas and then there's fluid next to it is where you'll see an air fluid level, but you'll only see this on an upright patient. If they're supine or prone, you won't see the air fluid level. So it's important to know, but you will typically see that air fluid level in the stomach, which is pointed out on this radiograph. And then you'll see sometimes 2 to 3 air fluid levels, though sometimes less, in the small bowel. So in this case, you can see a very clear air fluid level located right here in the small bowel. And there's usually not any air fluid levels in the colon. So you'll see significant amounts of gas in the colon, but you will not typically see any air fluid levels because one of the primary functions of the colon is to reabsorb fluid. And so typically you don't get this accumulation of fluid in the colon. There's also almost always air in the sigmoid and rectum. So you'll commonly see, as you see in this image here, these gas bubbles that are located down there in both the sigmoid and the rectum. And stool can be recognized by multiple small gas bubbles within a mass. And so I think a better example of that is shown right here. So you can see this is clearly a mass, and notice how there's all these little bubbles in it. So that represents stool, what you're looking at right there. So in this image on the left, is the large bowel distended or not? And you want to get a sense of what the large intestine typically looks like on imaging. What is the typical size of the large intestine? And so this is a good example. This is a good one to learn from, to get a sense of what the large bowel normally looks like in terms of size. So remember, and we'll talk here in a moment about the 3-6-9 rule. But for right now, just study this and get a sense of what does the cecum normally look like, what does the ascending colon look like, the hepatic flexure, transverse colon, descending colon, going down into you can see the sigmoid colon into the rectum here. Clearly, you get a pretty good sense, I think, of what the large intestine normally should look like with this barium study. So in this case, take a moment and look at this image and see if you can figure out what's going on with this patient. So this is a patient that has severe constipation. So you can see how he has kind of this mottled appearance, and that indicates that they have significant stool accumulation throughout their large intestine. And then in this case, it kind of looks like the bottom of a swimming pool. This is called aerophagia. So this is where the patient has swallowed significant amounts of air, and now you're seeing a lot of air in the intestinal tract. And so this is typically what that appears like on imaging. So it's not necessarily a pathologic condition, it just means that they swallowed a lot of air for whatever reason. This is a child that had swallowed a coin, and coins oftentimes will lodge in the esophagus at various points, which we'll talk about here in a moment. But when you look at it in coronal or in an AP view, usually the coin will be in a coronal orientation. However, you'll notice on the image on the right here, where now this is a different patient, but in this case, clearly the coin is not it's in a sagittal view, not in a coronal view. So it's not always in a coronal plane, but oftentimes it is. And so in terms of the common sites where a foreign body might become lodged in the esophagus, We have the upper esophagus at the level of the thoracic inlet. So that's going to be the first location. Then at the level of the carina and the aortic arch. So especially the aortic arch is going to be putting a little bit of pressure on the esophagus and causing it to be somewhat narrowed. So and again, this is a normal physiologic narrowing at the mid-esophageal level. And then finally, the distal esophagus, just above or just superior to the gastroesophageal junction, that's going to be the final location of esophageal constriction. So that's another location where you might expect to see a foreign body become large in the esophagus. And again, it's very common for children to swallow foreign objects, foreign bodies, even when they're well watched after or closely monitored. So now I want to talk about differentiating between large and small bowel on abdominal X-rays. So the colon, just to remind you, it's got an average length of about 1.5 meters. But note that the Taenia coli are only about 30 centimeters, or they are about 30 centimeters shorter than the colon. And so as a result of that, you get the sacculation formation within the large intestine. And remember that we call these sacculations haustra. So again, you can appreciate the haustra here in this image. And then you'll also remember that you have epiploic appendages dangling off of the various parts of the large intestine. So you want to keep that in mind because those are going to be just fat globs. And so they won't have any sort of lumen or anything else. So if you see an outpouching coming off of the large intestine, you notice that it has a clear lumen that indicates it's a diverticulum and not an epiploic appendage. Another thing to keep in mind with the large bowel is that it's going to be located peripherally. So you can see in this image how the ascending colon is over on the right, far right side of the abdomen. The descending colon is on the far left side. Of course, you do have the transverse colon coming across the midline, but it again stays sort of away from the midpoint around the umbilicus or umbilicus. So again, it is still relatively peripherally placed, and same thing with the sigmoid and rectum. They're both going to be located relatively low in the pelvis. So this is a nice barium study where you can really appreciate the colon. I mean, you can see the distal ileum, especially right here. You can see where the ileocecal junction is. So this is going to represent the cecum. You can see the ascending colon, hepatic flexure, the transverse colon, the splenic flexure, descending down here into the descending colon, and then eventually we're making our way through the sigmoid colon and then the rectum down here. And so again, these are all relatively fixed in place. Looking at the small intestines, the small bowel, remember that you have plicae circulares located throughout the small bowels, but they're most prominent in the jejunum, which gives it that sort of feathery, airy look, and then they become smaller, less prominent, more distally, where at the terminal ileum they're virtually gone at that point. Also remember that there is a difference in the appearance of the jejunum, which you see here on the left, versus the ileum, which you see here on the right. So remember that the mesenteric fat comes higher up on the ileum compared to the jejunum. You have a somewhat larger diameter of the jejunum relative to the ileum, and then those plicae circulares are going to be noticeable there as well. And if you do a vascular study, you'll notice the difference appearance of the vasa recta and the arterial arcades in the jejunum versus the ileum. So just keep those items in mind. So now looking at a comparison between large versus small bowel. So you notice on the left-hand image, we're looking at the large bowel. So you can see these relatively large haustra throughout the large intestine. And so notice the distance between them and the size of them. They're clearly quite large relative to the plicae circulares. And so again, you can see these little tiny plicae throughout the small intestine. Again, you can see more down here. So that tells you that you're definitely looking at small intestine versus large intestine, or small bowel versus large bowel. In terms of the normal diameter of the bowel, again, there's a rule that you can use to determine this, and so it's called the 3-6-9 rule. 3 centimeters is again the approximate size of the small bowel. Remember, earlier we said it's about 2.5 centimeters, but 3 centimeters is for good for this rule. 6 centimeters approximately for the colon, and then about 9 centimeters for the cecum. So the cecum is going to be the largest of the structures. So you can kind of use all that to help you determine whether you're looking at a distended bowel or a dilated bowel. And on this right-hand image here, I just wanted to point out, you can really clearly see here the distal ileum as it's joining with the cecum, and you can see the cecum moving into the ascending colon, transverse colon, splenic flexure, descending colon, sigmoid colon, moving down into the rectum. And then over here you can get in a good sense of we've seen this already, but just seeing that feathery appearance of the jejunum, and then as you move towards the cecum, you can see how the ileum sort of loses those plicae as it travels further and further distally. So in this image, you want to make sure that you can identify the distal ileum, which I pointed out before, the cecum, the appendix. If you look really closely, you should be able to identify that coming across right here. We have the ascending colon, hepatic flexure, transverse colon, splenic flexure, descending colon, and then again about this point we're transitioning into the sigmoid colon, and then down here you can see the rectum. And then notice the diverticula, or diverticuli rather, that are outpouching off of you can see one over here as well, which are these outpouchings coming off of the large intestine. So don't confuse these with epiploic appendages. Again, you typically will not see, you're not going to see epiploic appendages with contrast inside of them, because obviously they don't have a lumen, they're not actually connected to the inside of the large intestine. So that's a good way to differentiate those from epiploic appendages. So looking at this image, again, this is showing you that small bowel that we looked at previously. And so this is a good image to work on, trying to differentiate between the small intestine. So again, you can see jejunum up here, clearly some of the ileum down here, and then the cecum over here. You can also see the stomach. So you can see the stomach where it's transitioning into the duodenum and then moving into the jejunum ultimately. Here's another upper GI study with small bowel follow-through. So you can see the stomach up here, again moving down into the duodenum, and then over here we see the jejunum. Over here you can clearly see the ileum. And then just another example here where you can see the jejunum and the ileum, but notice that there is a significant pathology that this patient has. And so this is what we call the string sign. So this is a narrowing of the terminal ileum due to Crohn's disease. So it's a chronic inflammatory bowel disease that is causing this significant narrowing of the terminal ileum. Here's another individual with very significant pathology. So if you look at the large intestine, you can again clearly see the hepatic flexure, the transverse colon, and then you'll notice that there's this sudden narrowing of the large intestine right there. And so this is what we call an apple core lesion. So it kind of looks like an apple core with these large dilated ends with a narrow constriction, what we call an annular constriction, which is caused typically by a carcinoma of the colon, so colon cancer. And then calcifications are relatively common on abdominal images, especially down in the pelvis. So phlebolyths are calcified venous thrombi that you can appreciate some here in this individual. You can also see calcified rib cartilage in this person as well. Again, if you follow the anterior ribs around, that's where you can see a bunch of these calcifications. And then just looking at a little bit better view of phlebolyths, here you can see a number of them located in the pelvis. These are normal findings. They're actually not of significant concern, but they're very common, especially in older folks. And then this is a young child that had been complaining of belly pain and vomiting, and so they have evidence of gallstones, which are circled there on the screen for you. This is an even better view better example of gallstones. You can see the gallstones located right here. This person obviously has a significant number of them. And gallstones, by the way, are not always easily observed on an X-ray, on a plain film radiograph. In fact, the better way to diagnose it is using ultrasound. And so you can see this is a great example of ultrasound So this is the gallbladder. You can see the lumen of the gallbladder right here, and then there's a number of stones down here which are echogenic. So you have this what we call highly reflective echogenic gallbladder stones or gallstones. And so what's going to happen here is because they're highly echogenic, you're going to have this shadow that shows up distal to them or behind them, and so we call that acoustic shadowing. And again, that is virtually always indicative of gallstones. Then over here you can see part of the liver as well on this ultrasound. And this is a CT scan, so we'll get more into this in the next module. But you can see once again the gallbladder right here with the liver. You can see the kidneys over here, the aorta, and these are all gallstones that are stuck here in the lumen of the gallbladder. And so again, just note that if the stones are pure cholesterol, they're going to be hypoattenuating, and so you won't see those on X-ray based imaging modalities. But the calcified gallstones are hyperattenuating to bile, and so you'll be able to see those. But again, it's possible that they can be isodense and therefore missed on CT.